Good morning, everyone. Today we'll be talking about the management of cardiogenic shock. So this is the scope of my talk, the definition of cardiogenic shock, how to recognize it, what are the causes, acute ischemic causes versus non-ischemic causes, what are the stages of cardiogenic shock, risk factors and prognostication. We're coming to the actual pharmacotherapy, revascularization, and mechanical circulatory support. We'll start off with a couple of cases. 42 years old Indian gentleman, recently detected to have diabetes, hypertension, and hyperlipidemia, had acute severe chest pain, and he collapsed twice before coming to the ER. The heart rate was 42 per minute when he came. The blood pressure was 70 by 50. So by definition, this is cardiogenic shock. And this was the ECG when he came in. This is about a year ago. You can see on the ECG, huge ST segment elevation in L2, L3, AVF, as well as in V4, V5, V6. There is ST depression L1, AVL, and there are changes of posterior wall as well on the ECG. So the patient, and if you look at the rhythm, you can see the P waves are marching through the QRS. You can see these P waves, they're actually marching through the QRS. So the patient is in complete heart block with a massive inferior wall MI plus a posterior wall MI plus an RVMI. Echo showed regional wall motion abnormality in the inferior, posterior, but surprisingly anterior and apical segments as well. So we took this patient for an angiography, suspecting that there might be multivessel disease. So the left injection shows that the LAD was totally occluded chronically. The LCX had an 80% lesion, and the RCA, which was the culprit, had a thrombus causing total occlusion of the proximal RCA. So we knew the RCA was a culprit, so we went on to do the RCA angioplasty. These are the running images. A wire is passed, and then a stent is positioned. And after the stent is deployed, you can see good flow is achieved. And so these are the images before and after the angioplasty is done. So how did we manage the cardiogenic shock in this patient? Luckily, his rhythm before we started the PCI came back to sinus rhythm. So we were able to maintain AV synchrony. Had it not happened, then we would have to put in a temporary pacemaker. He had an RE infarction, so we gave him bolus of IV fluids. And but since there was LV dysfunction as well, he started going into pulmonary edema. So in order to improve his LV as well as RV function, we started him on inotropes, and he stabilized after 48 hours in the ICU. So that case was a case of acute MI with cardiogenic shock managed without any devices. The second case, 56 years old Indian gentleman, hypertensive on irregular treatment, chest pain the previous night, worsened in the morning, brought to the ER. This is about 3 months back. When he came, it was ongoing chest pain, pulse 80 per minute, blood pressure 110, 80 initially. And then echo showed anterior wall hypokinesia, EF was only 40%. And as we were trying to talk to him, he suddenly collapsed, went into cardiac arrest. This was the rhythm. As you can see, initially he had VT, which degenerated to VF. And then immediately CPR was started. 10 minutes of CPR was done. 5 shocks were given to this patient. And then after 10 minutes, ROS was achieved and he regained consciousness. BP was around 80 to 90 by 60. And took him for angiography, did the femoral access. The opening blood pressure was 65 by 45. In the ER, it was about 85 to 90. By the time we shifted him to the cath lab, it was around 65. Started him on an noradrenaline infusion, and then we did the angiography. We can see here there's a very tight lesion in the proximal LAD here, and with very slow filling of the LAD. You can see the LAD is actually filling very slowly. So put in a stent, and this was the angioplasty to the LAD. Good result. But then because his blood pressure was low, we put in a device called IABP. So this is the positioning of the device. So we place it just lateral to the, just distal to the subclavian artery. And you can see the balloon here expanding and collapsing, inflation and deflation of the balloon. So how did we manage the cardiogenic shock in this patient? We did the primary PCI to the infarct-related culprit artery. The other 2 arteries were not addressed at this time. He was brought back later for the angioplasty of the non-culprit vessels. Noradrenaline infusion started in the cath lab itself. And then after that, we put in IABP after the PCI was done. It required IABP for about 8 hours. And then the pressure started improving. And then we were able to wean off the IABP. but we continue noradrenaline for about 24 hours. So cardiogenic shock, by definition, is a state of systemic hypertension lasting more than 30 minutes with reduced end organ perfusion due to a low cardiac output state, despite adequate filling pressures. So it is not a hypovolemic shock where the volume is low. Here the filling pressures are good. Or the patient is already on vasopressors or requiring mechanical circulatory support. So these are the criteria. Persistent hypotension, more than 30 minutes. Hypertension is defined as systolic pressure less than 90 millimeters mercury, reduction in cardiac index less than 2.2, elevated left ventricular filling pressure, that is the capillary wedge pressure more than 18, and signs and symptoms of end organ hyperperfusion. The causes, most commonly, it is because of acute MI, around 70 to 75% cases are because of acute MI. And in acute MI, the most common cause is LV systolic failure. So a patient comes with like this with an acute MI, the entire anterior wall is gone. If the patient loses about 40% of the mass of the LV, then he can land up with cardiogenic shock. RV infarction, these patients are very prone to cardiogenic shock because RV is a very thin ventricle and it has the pumping power of RV is very slow, very low. And if the patient has arrhythmias like bradyarrhythmia or an unstable tachyarrhythmia, or if the patient has mechanical complications like a ventricular septal rupture, a free wall rupture, or a papillary muscle tear. Now, these are the most common cause of cardiac shock in patients with acute MI. The non-infarct related LV failure can happen, most commonly in acute myocarditis. This is more commonly seen in younger adults. There can be critical ischemia without an infarction. We had a patient who had a very critical ostial left main disease, but there was no MI as such that had hypotension. In cardiomyopathies, like a dilated cardiomyopathy or peripartum cardiomyopathy in women can also cause, can give rise to cardiogenic shock. Drug toxicity like excessive dose of beta blockers can cause cardiogenic shock. And if there is obstruction to the cardiac flow, as in critical aortic stenosis, severe mitral stenosis, a massive pulmonary embolism, or a stuck valve. Prosthetic valves, particularly the metallic prosthetic valves when the patient are on anticoagulation, if their INR is not at target range, there can be a thrombosis of the prosthetic valve, and this can cause obstruction to the cardiac flow. An acute valvular regurgitation can happen from endocarditis or from a caudal rupture due to MI. Then there can be decompensation of the chronic heart failure. Then other causes are cardiac tamponade, aortic dissection, post-cardiotomy. The patient had a bypass surgery or a aortic valve surgery, and then these patients, it manifests typically as failure to wean from the pump. Then post-cardiac arrest patients. So these are the most common causes. As you can see in this graph, predominantly it is LV failure due to an MI. So it's around 75% of the patients. RV shock is about 3%. VSR is about 4%. Acute MR is about 8%. Tamponade is about 1 to 2%. Now, also, mind you, the shock can evolve as you see the patient. So in the shock registry, which is from 1995, what they found was out of the total patients, only 25% presented with shock in the ER. But within 24 hours, the other patients landed up in shock. In the Gusto trial as well, only 11% of the patients were in shock when they came to the ER. So shock can develop after an MI as you're treating the patient. So we have to be very careful about monitoring these patients. Now, the stages of cardiogenic shock, the Society for Cardiovascular Angiography and Interventions has given a very beautiful classification, 5 stages, stage A to D. Stage A is a hemodynamically stable patient who has not yet developed any signs or symptoms of shock, but is at risk of development, like a large anterior MI or a decompensated heart failure. So this patient is not in shock, but they are at risk. B is the beginning of cardiogenic shock, wherein there is some clinical evidence of hemodynamic instability. You're finding blood pressure on the lower side, say 90, 95, tachycardia, heart rate more than 100, abnormal hemodynamics, but there is no signs of hypoperfusion yet. Capillary filling time is maintained, good distal pulses are maintained. So these patients are in the beginning stage of cardiogenic shock. In the classic cardiogenic shock, wherein the patient has already developed clinical evidence of hypoperfusion, and that may require pharmacological or mechanical support, usually with hypotension. Then deteriorating, stage D is deteriorating. wherein the patient has evidence of shock that worsens or it fails to improve, though you're giving all sorts of therapy, pharmacological as well as mechanical. And stage E is the extremis, where the patient is with refractory shock or actual impending circulatory collapse, like patient throwing a VT storm, or in a patient in pulseless tachycardia. So these are the patients who are in extreme stage. And depending on the stage that they are in, it translates into mortality. Like patients at risk, like I said, a large anterior MI. In hospital mortality may not be much, but long-term mortality is quite high, about 25%. And when the beginning stages, in hospital mortality rises up to 2.7%. In the classic stage, the in-hospital mortality itself is around 20%, whereas the long-term mortality can be as high as around 50%. And when the patient starts deteriorating, the in-hospital mortality is about 50%, long-term about 60%. And the patient has gone to the extremist stage, so the in-hospital mortality is 90, and the long-term mortality is 95. And this is despite treatment. The management involves early recognition of the shock and prompt reversal of the underlying causes, restoration for tissue perfusion so that you can prevent acute kidney injury, you can prevent shock liver, and you can prevent other organ damage. Then pharmacotherapy and mechanical support. The initial recognition should focus on identification of end organ hypoperfusion. So you're able to see delayed capillary filling time, you're seeing oliguria, you're seeing raised liver enzymes. So all these things could be signs of severity of shock. Hypoperfusion can manifest as altered mental status, oliguria, or cool extremities. There can be signs of congestion because these patients have concomitantly cardiogenic shock and sometimes pulmonary edema. So they may have tachypnea, pulmonary edema, raised JVP, peripheral edema if they've been for a long time, and then hypotension with a narrow pulse pressure and a compensatory tachycardia. So these are the signs of cardiogenic shock to evaluate. Non-invasive testing, routinely ECG, chest X-ray, and an echocardiography. Echocardiography is a must. A quick bedside echo is at least important, so you can see the status of the left ventricle and the right ventricle. You can see if there's any acute mitral regurgitation. You can see there's a ventricular septal rupture or a free wall rupture. You can see signs of tamponade. And then lab testing is important, so look for the ABG. Look at the lactic acid. Lactic acid is a very good marker of prognosis, and they actually recommend to check lactic acid every 2 to 4 hours until the patient settles down. So a worsening lactic acidosis portends a very bad prognosis. Coming to invasive hemodynamic monitoring, there was a trend when all these patients used to get pulmonary artery catheters. Then all patients with shock, cardiogenic or otherwise, used to get pulmonary artery catheters. But then the complication rates were higher. You saw infections, we saw bleeding, we saw all sorts of problems. And then the large trial data did not show any benefit of PA catheters in the overall subset of patients having cardiogenic shock. But there was a registry wherein in exclusively patients with MI-associated cardiogenic shock, hemodynamic profiling with pulmonary artery catheter was associated with improved outcomes, including mortality. However, routine use is not advised in these patients. Now, it's almost most important to treat the underlying cause, like if the patient presents with acute MI. So emergent culprit vessel revascularization is the only intervention that has shown improved survival in randomized controlled trials. The first trial was from the shock trial in the 1990s. So it was a large trial which compared emergency revascularization versus initial medical stabilization. And there were two endpoints. The primary endpoint was 30-day mortality. Secondary endpoint was 6-month and 1-year mortality. And these were the results. If you look at the primary endpoint, so in immediate revascularization, it was about 46%. And patients who got medical stabilization as the initial strategy, it was about 56%, significant there. And this translated into 6 months mortality as well. There was a huge difference, about 13% difference in the outcomes. And this actually persisted when they studied for the next 5 years. So the difference between immediate revascularization versus medical stabilization persisted in these patients. So the AHA guidelines recommend early revascularization with either PCI or CABG for patients less than 75 years old with ST elevation or new LVP who develop shock. More than 75 years, in the same trial, a subset was studied where elderly patients more than 75 years did not benefit from a routine invasive strategy. Now, where invasive strategy is not possible, the second option is to give a fibrinolytic therapy. And also, mind you, if the patient is unstable, so the preference is to do only culprit vessel PCI. And that came from this trial, the shock culprit trial. So it was about 700 patients with cardiogenic shock, acute MI, multivessel coronary artery disease. So patients who got only culprit artery PCI, uh, the mortality was about 50%. And patients who got multivessel PCI, the mortality was 56.9%. And so there was increased mortality when we tried to put in multiple stents in a patient with cardiogenic shock. Now, other causes that need to be treated, patient is having a bradyarrhythmia, we need to place the patient. He's having an unstable tachyarrhythmia, like VT, VF, or AF, or SVT, which is with the shock, then we have to cardioid these patients. If there is acute valvular disease, let's say acute mitral regurgitation, so we have to do something, some intervention, either percutaneously or surgically for that. If the patient has tamponade, of course, we need to do a pericardiocentesis. One important treatment for acute myocarditis is immunosuppression. Particularly in children and young adults, if they present with acute myocarditis, they respond very well to IV immunoglobulins. Now, coming to the medical management of cardiogenic shock, so after we identify the underlying causes, we go for vasoactive agents. So we have vasopressors, we have inopressors, inodilators, and vasodilators. Mind you, almost all of these vasoactive agents, they cause increased myocardial oxygen consumption, and they have an increased risk of arrhythmia. So use the lowest doses required for the shortest duration possible. That should be the mantra. Now, some experts have recommended norepinephrine as the initial agent of choice. There was a trial called SOAP trial in which patients with cardiogenic shock, when they were treated with norepinephrine, they noticed lower rates of death and arrhythmia compared with dopamine. There was another small trial called Optima CC trial where they compared epinephrine versus norepinephrine, and they found norepinephrine had lower rates of refractory shock, lower lactate levels, and less tachycardia compared to epinephrine. However, epinephrine is usually widely used in post-cardiotomy patients. Our surgeons like to give epinephrine, usually low doses. Sometimes you may have to combine two agents like norepinephrine plus dobutamine or something like that. In patients whose blood pressure is a bit okay, say around 100, 110, we can start these patients on inodilators. So basically, this is dobutamine and milrinone. So these patients, these agents, they increase the contractility of the heart, but they cause some vasodilatation. So before we start these, we should make sure the mean arterial pressure is adequate, because otherwise, because of the vasodilator properties, the blood pressure can fall rapidly. Milrinone is more commonly used in pediatric patients with non-ischemic cardiomyopathies. These are the different agents, the vasoactive agents. Vasopressin is rarely used in cardiogenic shock because it increases myocardial oxygen demand and can cause worsening of ischemia. Phenylephrine can be the agent of choice if there is hypertrophic obstructive cardiomyopathy, but it can result in reflex bradycardia. Now, coming to norepinephrine, epinephrine, and dopamine. So the receptors are a little different with epinephrine. It acts more on the beta-1 receptors, whereas norepinephrine is more on the alpha-1 receptors. Both of them have increased risk of atrial and ventricular arrhythmias. So try to use the smallest dose that is required and try to wean off the patients of these agents as soon as possible. Already discussed dobutamine and milrinone. So they increase the contractility and reduce the systemic vascular resistance. And when the pressures are on the higher side and the patient has continuous ischemia, then we can give these patients nitroglycerin or sodium nitroprusside. But we have to be very careful in monitoring these patients' blood pressures. Now, coming to mechanical circulatory support, this has come up in a big way in the last few years. What the mechanical circulatory support devices do is they provide hemodynamic support. So they're increasing the blood pressure and they increase the end organ perfusion without increasing the myocardial oxygen demand. Now, all the inotropes, they increase the myocardial oxygen demand. So this is the advantage. So they can serve as a bridge to recovery. So patient with an acute MI, you put in device, let him recover, or to an intervention, a patient who is not suitable for intervention. Say a patient is posted for CABG, but he cannot undergo CABG because the pressures are very low. So you put these patients on MCS and you can send the patient for CABG. Nowadays, we're also doing high-risk PCI with mechanical circulatory support. There is, say, severe LV dysfunction, multivessel disease. So we put in one of these devices. So it helps us tide over the crisis of the PCI. So most common mechanical assist devices are IABP, Impella, ECMO, and tandem heart. We'll see each one of these. IABP is the most commonly used form of mechanical circulatory support. It's been there for almost more than 2 decades. Basically, it is a mechanical volume displacement device traditionally used in patients with cardiogenic shock during PCI and CABG. So there is a balloon made of polyurethane that is accessed from the femoral artery. And this balloon is positioned just distal to the origin of the subclavian artery because we don't want to compromise the flow into the subclavian artery here. And what happens is it inflates during diastole. So when the heart is relaxing during diastole, the balloon inflates. When the balloon inflates, the pressure in the ascending aorta rises, and that pressure is transmitted into the coronary arteries. So the coronary perfusion filling pressure increases. And during systole, when the heart is contracting, this same balloon goes negative. So it deflates. And because of the deflation, rapid deflation, it creates increased flow into the aorta. So the heart is able to pump flow of blood into the aorta. So there is decreased cardiac work, there is decreased myocardial oxygen consumption, and there is increased cardiac output. So this is how the balloon looks. So we have to be very careful in positioning the balloon. One is to look at the subclavian artery. Second is look at the renals. When you go down, you have to look at the renals so that the renal arteries are not compromised. The indications, classical indications for IABP, cardiogenic shock in acute MI, particularly if somebody has a mechanical complication, like a ventricular septal rupture, or an acute mitral regurgitation, or severe refractory myocardial ischemia, where the patient continues to have ongoing angina with multivessel disease or a left main stem stenosis. These are the classical indications to put in an IABP. And high-risk PCI during shock. These are the classical indications. Electively also, if there's a high-risk PCI, we can do a prophylactic IABP insertion. And if there's a difficulty in weaning a CABG patient or a valve patient from cardiopulmonary bypass, IABP can help. And also, it can serve as a bridge to cardiac transplant, though the FDA recommends only 2 weeks for the IABP to stay. But people have used a subclavian IABP rather than a femoral IABP. So they make us cut down in the subclavian or the axillary artery, and through that the IABP goes in. So that can stay longer, that is easier for the patient to move around, to mobilize, and has lesser complications. And there are certain contraindications. The absolute contraindications are severe aortic regurgitation. So otherwise, each time there is inflation, it will push more aortic blood into the LV. Of course, aortic dissection, severe peripheral vascular disease, and a non-salvageable patient. These are absolute contraindications. Relative contraindications are prosthetic vascular grafts in the aorta, aortic aneurysm, aortofemoral grafts, sepsis. Now, this is how the IABP graph looks like. This is actually from our last patient. So we've used the ECG as a trigger here, and these are the pressures. So now this is the systolic blood pressure of the patient, 117, and the diastolic pressure is 81. And look at this augmentation pressure. When the balloon inflates, the pressure goes up to 133. So the difference between this augmentation pressure and the systolic pressure, this is what will drive the blood into the coronary arteries. And this can be triggered either 1:1 or 1:2 or 1:3, depending on these things. If the patient is in atrial fibrillation, you cannot use ECG, then you can use a pressure as a trigger. The complications of IABP, limb ischemia, because you are putting through a femoral artery and the patient is not able to move. So 10 to 20% chance of limb ischemia. So the machine comes with an inbuilt Doppler. So you keep monitoring the peripheral pulses, the dorsalis pedis and the posterior tibial arteries. You can feel with the Doppler. The balloon can rupture sometimes, very rarely. There can be thrombosis within the balloon. So you need to anticoagulate these patients very well. And because you're anticoagulating, the risk of bleeding is going to be there. Infection can be there. Vascular complication in the femoral artery can be there. Aortic wall dissection or rupture can be there. And sometimes embolization can occur. Either thrombus or plaque, or sometimes air can escape from the balloon into the aorta and cause problems. So we try to put it for as short duration as possible. Now, coming to the next device, it's called Impella. This is a wonderful device. It's been available for almost about 10 years now. The axis is usually femoral for the Impella 2.5 or Impella CP. So it goes from the femoral artery, goes into the aorta, and then crosses the aortic valve and lands in the left ventricle. So the blood inlet area is in the left ventricle. The blood outlet area is in the aorta, and there's a motor pump. So this motor, it sucks in blood from the left ventricle and throws it into the aorta. So it's basically unloading the left ventricle. So the work of the left ventricle goes down. On fluoroscopy, this is how it looks like. So this tip is in the left ventricle, and this is the pump, and this is in the aorta. The larger Impella, which can take up to 5 to 5.5 liters output, it is done by a surgical cut down in the subclavian artery. Now, the physiological impact of the Impella is because unloading the left ventricle, so it decreases the end diastolic volume of the left ventricle, it decreases the end diastolic pressure. And by doing this, it decreases the demand of oxygen demand on the ventricles. It increases the aortic pressure, it increases the flow, and thereby it increases the cardiac output. The limitations, again, access site complications, it's usually a 14 French sheath, so quite a big sheath that needs to be put in. Significant risk for hemolysis, particularly if we're going to keep this for a week or more than a week, then there can be hemolysis because of the metal component with associated renal failure. There can be thrombocytopenia because of the hemolysis and increased bleeding. It is more invasive. It needs immobilization of the limb, and it needs fluoroscopy, and of course the cost can be expensive. The classical indications for Impella usually nowadays are high-risk PCIs. Patients with LV dysfunction, patients with multivessel disease. So these patients, usually we are doing an Impella. Now, also, but if the patient has aortic valve disease, you cannot use this. If the patient has a severely calcified aorta, you cannot use this. Otherwise, you increase the risk of embolism. Now, there is an Impella for the right side as well. Sometimes when there is RV failure, we need to support the right ventricle. So here you access through the femoral vein, and you leave the inflow in the vena cava and outflow into the pulmonary artery. So you're bypassing the right ventricle and making the blood flow from the vena cava into the pulmonary artery directly. Again, placed under fluoroscopic guidance. No sternotomy required. Maximum flow is about 4 liters per minute. The last device I'll discuss is ECMO. So ECMO is extracorporeal membrane oxygenator. So what we use is veno-arterial ECMO. So it provides cardiac as well as pulmonary support. So basically, you're improving the circulation as well as you're improving the oxygenation. So if the patient has cardiogenic shock with respiratory failure, this is an ideal indication. There are two types of ECMO, peripheral VA ECMO and central VA ECMO. In peripheral VA ECMO, the cannula is in the femoral vein. Through the femoral vein, it goes into the pump, then it gets oxygenated and goes back into the arterial system. When we use a central VA ECMO, the cannula is in the right atrium, and from there it goes into the pump and then goes back into the left atrium. So the advantage is oxygenation, of course. So it is providing circulation, oxygenation, improves end organ perfusion. It unloads the right ventricle more than the left ventricle. But if the patient has severe LV dysfunction, the LV is compromised, so there will be a lot of blood going into the left atrium, from the left atrium into the left ventricle. And so that can precipitate what we call as increased pressures in the LV, increased oxygen demand. So for this reason, if a patient has LV dysfunction and veno-arterial ECMO, you need to put in another device to unload the left ventricle, which is usually an Impella again. There was a trial on ECMO in cardiogenic shock. This was done recently, and this was about 117 patients in 4 sites. But they did not find any superior outcomes when they did an immediate implantation of VA ECMO compared with initial conservative therapy. So these devices are good to tide over the acute crisis, but good amount of mortality benefit has not been shown in trials except in Impella to some extent. Now, summarizing, these are the key points for the day. So cardiogenic shock is defined by impaired cardiac output resulting in hypotension and end organ hypoperfusion. There is a classification, SCAI classification A, B, C, D, E, ranging from at risk to extremis. Multidisciplinary team is usually required because these patients have multiple organ dysfunction, kidney dysfunction, liver dysfunction, respiratory, critical care, all these things are required. Pulmonary artery catheters can be used in a subset of patients with severe cardiogenic shock. And treatment can include vasoactive agents. And if the vasoactive agents are not adequate, then we can go to mechanical circulatory support. Right. Thank you. Thank you so much.